Hello, my name is Tim Adams, and I'm the President and CEO of the Institute of International Finance, and I want to welcome you to our annual Washington Policy Summit. We have a full agenda for you today, and I urge you to look at the agenda. It's on our very handy app. I also urge you to use the app as a device for asking questions of our panelists. We'll use that throughout the day. We're going to start the morning with obviously the top topic, which is an update on the COVID-19 pandemic virus. And we have with us this morning one of the leading global experts. His name is Dr. Michael Osterholm. He is the Regents Professor and McKnight Presidential Endowed Chair in Public Health and Director of the Center for Infectious Disease Research and Policy at the University of Minnesota. He's also the author of an excellent book entitled Deadliest Enemy, Our War Against Killer Germs. If you haven't purchased the book, I strongly urge that you do so. Dr. Osterholm, we appreciate you being here today. The stats greeting us this morning continue to be grim. 600,000 cases in the United States, over 2 million cases worldwide, 27,000, almost 28,000 deaths in the United States, 133,000 deaths worldwide. Other headlines, the Washington Post has chaotic search for virus treatments undermine effort. The risk, many trials, little useful data. And just below that, just below the fold, executives paint push to reopen nation as haphazard, although there will be an announcement today from the White House on a plan to reopen the U.S. economy. Dr. Osterholm, if you could just take a few minutes and give us your assessment of where we are in the process of understanding the extent of this virus and a possible pathway forward. And thank you for joining us here today. I know you're incredibly busy. I've watched you throughout the last few weeks, and we're really fortunate to have you with us here today. So, Dr. Osterholm, it's all yours.
Well, thank you very much, Jim. It's great to be with you today, and I'm glad to be able to share these moments with all of you to provide an update on where we're at with this pandemic of coronavirus infection. First of all, let me start out by saying that this is new territory for all of us in public health, as we've never had a worldwide pandemic or outbreak in countries throughout the world of a coronavirus like this. SARS and MERS, two other coronaviruses, had very different characteristics in how they were transmitted, meaning they were transmitted mostly after people had been sick for several days. They lent themselves very much to control and containment. This is a very different coronavirus. This is acting very much like an influenza virus and what we might expect to see in an influenza pandemic. And so for all intents and purposes, our planning, our response is really focused on an influenza-like pandemic. So today, let me just give you a sense of where that is taking us. We have been tracking this situation very closely since the end of December in Wuhan, and I must tell you that it has not yet surprised us in terms of where it's going. We had predicted in the middle of January that this would cause a worldwide pandemic, that it would not show up in sufficient numbers of cases in countries around the world till the end of February. It would take that long before enough transmission cycles had occurred in these countries. And then when it would take off in certain metropolitan areas in substantial numbers, like we've seen in Italy and the Milan area, in parts of Spain, in the United States, and that would not be a surprise. Now, having said that, then the real question is, well, where do we go from here? Many people, I think, believe, whoa, we're kind of over the hump and that we are now in a position to, in a sense, go back to recovery. Unfortunately, I don't think that's the case at all. And we just have to be very honest and sober about that, as we need to prepare for what I think is at least still another 16 to 18 months of very important activity with this virus. What I mean by that is just take a step back and look at what happened in pandemics like 1918, for that matter, even in a lesser way, in terms of severe illness in 2009 with H1N1. But what's often seen in an influenza pandemic, for which we yet do not have an explanation, is that when the virus emerges in a given area, it will spread around the world. It will cause these sporadic kinds of serious outbreaks in what we call a first wave. In 1918, cities like Chicago and New York were hit very, very hard by the virus, while cities like Minneapolis, Baltimore, Philadelphia, and Boston were spared. But everyone got on board about 6 months later when the second big wave hit. And that in that instance, that's when we saw so much of the severe illness and deaths. And at this point, we have to assume that that could very well be the possibility with this virus here. When we look at what's happened with influenza pandemics in the past, there have been 10 of them within the last 250 plus years. 2 started in the winter, 3 started in the spring, 2 started in the summer, and 3 started in the fall. There was no seasonality, and every one of them spread worldwide and had its major activity 6 to 8 months after the original appearance. It then continued, however, in waves that were much like what we saw in this first wave, you might say, of illness that continued for some time. In 1918, it lasted well into early 1920 before we finally saw the virus, in a sense, become a seasonal flu-like virus. Will that happen with this coronavirus? We don't know. But I will tell you one thing. This is a very highly infectious virus that is transmitted readily via just breathing. It is clearly transmitted by aerosols, meaning that you don't have to just be a couple of feet away from people. And I think that our public health messaging has been a bit confusing at times about the role the environment plays, hands, hand washing, touching your eyes, and the idea that if you're more than 6 feet away from someone, you're not likely to be infected. Based on the very infectious nature we see with this virus, we do believe it is more like a flu virus, where in fact you can fill a room up with the virus and aerosols just merely being in the conference room with someone else who's infected. The other piece about this virus that makes it very challenging is the fact that it is likely transmitted in a very significant way, at least 2 days, if not more, before one becomes clinically ill. And that is a very difficult kind of virus to contain, unlike SARS and MERS, where you're not really infectious, as I mentioned earlier, until later into your illness. This one, you can transmit much earlier. So from that perspective, how we control it is important. Now, in terms of where are we going to go from here, let me just give some perspective to this as we best know, and then I'll talk about what we're doing to control it and where we go with that. But, we've seen all this modeling done, particularly in the United States and some areas of Europe, about how big will this get, how long will it last. And I just remind everyone that statistical models are a combination of lots of assumptions and some black box. I'll grant you, I have had a fair number of hours of graduate statistics, so I think I have a little bit of understanding of this, but even still, I sometimes am bedazzled by the black box effort. So let me just take the models we have today and just say, in a sense, throw them out. And I don't mean that they haven't informed us with something, but if you take the University of Washington model, that is one that focuses on these 4 months right now, and with the idea that the U.S. is in a Wuhan-like lockdown. Or if you take the Imperial College model, that's looking at a period of 18 months, and it's looking as if the distancing only is marginally, or you might say moderately effective in reducing transmission. So you'd expect to get different results. But I think to give you a perspective where I think this is going, I will just summarize it easily where I come from in rural Iowa here in the United States. It has to play on Main Street to some pretty smart people. So I say, just look at this. We have 320 million Americans in this country. Of that, I think it's fair to say at least 50% by the time we get out of this will become infected with this virus. And that's a fairly consistent consensus finding from Medicology. Well, if you look at 50%, that's 160 million Americans. If you look at what we know about, even with asymptomatic cases occurring, about 80% of these people will have moderate to mild to basically non-existent symptoms. They won't seek medical care. 20% will seek medical care, of which about 10% of those will end up seeing a doctor and not being hospitalized. The other 10% will likely get hospitalized, of which about half or 5% of the total will end up requiring intensive care support, and about 0.5 to 1% in a conservative way will die. Well, that is anywhere from 800,000 to 1.6 million deaths. And to date, we've only had, and I say only with a great deal of pain and respect for those who have died, but we've had 23,000 deaths in the United States. That just gives you a sense of what I think many of us think we still have to go. Now, will our distancing activities slow that down, change that? We don't know. I like to think that we've had a big impact in places like New York and Seattle, in the other cities around the world, Milan. But in fact, remember in 1918, the first wave of illness came, did what it did, and left within oftentimes 6 to 8 weeks without regard to any of the human stuff. So one of the challenges we have is knowing where are we going with this issue and what can we do about it. Now, so having said that, the world has to be prepared to be in a constant state of adjusting and having to be responsive to what the virus is doing. Now, what can we do about it? Well, ultimately, the savior we need desperately is a vaccine. We don't know if we can obtain a vaccine. We have to understand, can we develop a permanent immunity that will protect us from any future infections? Can a vaccine be safe? I think we'll have answers to that within months. But even with that, the earliest any of us could imagine a vaccine being studied, being licensed, being manufactured, and being delivered is 18 or more months. So we are not going to get any free passes here for that time period. In addition to treatment, there are a number of treatment modalities right now that are being evaluated in Godspeed. And I don't know if any of those will work. I am hopefully optimistic there will be some that will lessen the severity of the disease and potentially keep people from dying. But it won't alter the course of the epidemic itself, because remember, the most infectious period likely is in that very earliest stages before somebody even gets sick. Those medications will not reduce the infectiousness of an individual. So we're going to have to be prepared to have this ongoing pandemic occur, hopefully, though, reducing the number of deaths if we can. I think the real challenge we have before us today is how do we maintain our everyday lives? How do we maintain business? We can't stay locked up. As we all well know, we will kill society in a sense just from that if we try to do this for 18 months. But we can't let cases just run willy-nilly. We'll bring down healthcare systems, as you saw, the verge of that happening in cities like Milan in New York, and what that will mean going forward. So we have to find a middle course. I like to liken it to threading the rope through the needle, where we have to understand how do we release people back into society, maintain what we can in terms of our economy, and at the same time being very responsive to should the virus activity start to pick up, that we actually can try with distancing to alter it. We may or may not be successful. We may just end up riding this situation out. So having said that, I'll end it there and just give you a sense that we will get through this. There's no question about that. 18 to 24 months from now, we will. I know also, though, in that time period, we will change the world in a very fundamental way. There will never be a normal again. It will be a new normal. And what we're all trying to figure out is how to get to that new normal in the way that minimizes on the number of deaths, the number of severe illnesses, and also minimizes on changing the society that we want to have versus the one that we've now been forced to experience. So with that, Tim, I'll turn it back over to you, and be happy to take any questions if you'd like.
Thank you, Dr. Ostrom. You know, one of the topics which just permeates the papers today, and there was an NPR story this morning, it's the issue of testing. Everyone is hanging their head on testing. If we can just test in sufficient numbers, then that is the gateway back to normality, even though, as you just pointed out, there is no going back to normality. Are we putting too much attention and too much faith in testing? I know I've heard you over the last few days talk about some of the statistical challenges of testing. Even under the best of circumstances, there are huge or high error rates that maybe some of our listeners don't quite appreciate.
Right. Thank you. In fact, I am writing an op-ed right now for the New York Times on this very issue. I think that for those of us in the United States that lived through the post 9/11 period, we came to believe in CIPRO, we trust, i.e. relative to the anthrax attack. Well, unfortunately, I think we've come to the same position in this pandemic within testing we trust. And there are many, many shortcomings about that. First of all, let me make it very clear that testing in of itself is not a panacea. The tests that we have right now, both for the virus in terms of the PCR testing and even the potential for antibody, have at best sensitivities and specificities in the mid-90s and likely lower. What that means is that for a sensitivity, as many of you may know, if you are infected, how often can you actually detect that infection? And if you're not infected, how often do we tell you you're not infected? And when we look at the population of the U.S. today and assume that 5% are infected, clearly in hotspots it's going to be higher than that. But the error rate that we see in terms of telling someone that they are infected when they're not, or that they have antibody when they're not, equals the actual total number of people that would actually really test positive. So there's a lot of problems with this test in terms of that. Second of all, in our country in particular, we have a severe challenge right now because of our what we did early on and fell behind in testing and the inability of the CDC to get a test out. We've been behind the 8 ball. And our government has reacted to that more from a political standpoint than from a science-based standpoint. And so the FDA basically opened the doors and said, hey, if you have a test, go ahead, just tell us about it. Under the emergency authorization, we'll let you just run it. And by the own declaration of a senior FDA official at a meeting last week among public health lab directors, acknowledged that 70 of the tests that were already out there for antibody studies, 35 of them, as he described, and these are his exact words, are junk. So we have a major challenge understanding what these tests mean. And it's very possible in some communities we'll be telling people to either have antibody when they don't, or they have the virus when they don't. More often than we're actually telling the people who really do, just by the performance of these tests. That's a challenge. So that's not going to get us the answer. But the second thing I just wanted to emphasize is that in Asia, which early on were able to, when the numbers of cases were still quite low, very aggressively test and then quarantine individuals, and forcibly so. Electronic monitoring, taking people from their homes and putting them in quarantine centers, etc. And everybody said, ha, that's the answer. Well, as you can see, Singapore today is in a state of emergency. 7 of the prefectures in Japan are in emergency status. We're seeing ongoing transmission in countries like Korea that had supposedly not have been stopped. And even in China, we're very concerned what's happening. They keep reporting out hundreds of people a day who are supposedly infected but asymptomatic, but only 1 or 2 clinical cases. That makes no sense at all. So I think even there, while we don't have a Wuhan-like experience, it's a much greater challenge, and it's not just a simple answer. In this country, are we prepared to do electronic monitoring? Are we prepared on test results that may be erroneous to take people from their homes, imprison people if they are not compliant with what we're telling them in terms of stay at home? There are a lot of questions yet that need to be answered. And I'm afraid we jumped on this one far too early in a hope, not a strategy, a hope that we can get the country back to some normalcy.
So there is the potential for a huge disappointment that we're hanging our hat on the testing as the panacea. To your point, just statistically, it's not going to be proven so, and just all the societal responses are challenges as well. And that, in many ways, is maybe a part of a second wave. We'll find that disappointing sometime in the fall, and I'll ask your assessment of when you might see a second wave. We could see disappointment on the inefficacy of testing, as well as a reemergence of the virus.
Yeah, I think you said it very nicely. Thank you. I think the challenge we have right now is we are at the limits of what we can predict with this virus in terms of what it will do, other than I'm convinced, as are my colleagues, that it will continue to go at the human population with vigor until it gets to probably 65 or 70% of the population infected and immune that way, or a vaccine develops that. That would give us that sense of herd immunity. We got a long ways to go to get there. What we don't know is, will it be more of a slow burn kind of phenomena where it just keeps day after day after day, continuing to transmit at some level to humans, or will we see it go away like we have in other past pandemics and then return in a vengeance? In 2009 with H1N1, we saw that spring peak in the Americas and some of the areas of Europe and even south of the equator in March, April of 2009. And then it just went quiet. Nothing we did to contain it. No vaccine yet. And then all of a sudden it appeared in late August, early September. And the peak wave in North America was mid-September to mid-October. Again, just that almost 6-month displacement away. We don't know if that's what's going to happen here. We're going to see the peak wave, which could be much larger than anything we've seen already. But I do know it will continue to be a challenge for us around the world. And I think that's, again, what we have to plan for, is that this is not, we're not one and out. As Sir Winston Churchill once very wisely said, this is not the end. This is not even the beginning of the end, but rather this is the end of the beginning. And that's where we're at right now. We're just at the end of the beginning.
One question, which is really a clarification regarding someone who's become infected. Can you become infected again? Or are you immune once you've had the virus?
Right. Well, first of all, we don't yet understand immunity completely and what it's going to take for someone to actually be immune and for how long they might be immune if they've been infected. I think most of us believe that is to be the case, but we still need data to support that. I think the question really relates to information that's been coming out of Korea over the last week about people supposedly getting reinfected. I have my doubts about that. And what I mean by that is that when you test by PCR, the polymerase chain reaction test, what that is doing is picking up the genetic material of the virus. That means you either pick up live virus, but also it's not uncommon with infectious diseases like this, where someone will shed viral debris, parts of the virus that were never, in fact, made into a full virus. And it's kind of like cleaning out your closet. And so I think in that regard, that may be what's happening in the Korea cases. We've tried to get information. We have no knowledge that anyone's ever been culture positive, meaning the virus was growing again after being negative for a period of time. So I think when this all comes out, it won't be reinfection. And we're hopeful that one can, in fact, develop an immunity to this virus after infection.
And another question, is it possible that the virus mutates in a way that as you're focused on a vaccine, it's a bit of a rifle shot, that you develop a vaccine for one iteration of a mutation, and yet 24 months later you have a different mutation? So you're constantly chasing the mutation aspect of this.
Well, first of all, this is good news. These coronaviruses are much more stable than influenza viruses. What I mean by stable, they're changing. But rather than changing completely in a way that would make them either less or more likely to cause severe disease or more or less likely to transmit, they age just like you and me. So, Tim, if we had snapshots of you from birth to today, we could see that you surely have changed a little bit, but in fact, it would not say that it was a different you. And that's the case we see with this virus. One of the things that has allowed us to understand the virus transmission as much as we have is that these minor mutations that occur actually occur at a very constant rate, almost like carbon dating an item. And so these are to be expected. It's what allows us to understand, did a virus likely come from the United States, from Asia directly? Did it come from Asia to Europe directly that way? But we don't have to worry about at this point any evidence that somehow the virus is going to mutate in a way like influenza virus might and change how it causes disease.
One last question, and then we're going to let you go. It's really a policy question. Can we somehow require the most vulnerable or expect the most vulnerable to stay at home, and those who are less vulnerable, who don't suffer from comorbidity types of challenges, they can go back to work? Can we, in some ways, segment society in a way that the healthiest go back, the least healthy stay at home?
You know, that's a great question, and it's one at the heart of what we believe has to be our policy going forward. You know, I've said time and time again, we're painfully learning how to die with this virus. We also have to learn how to live with it. And in that regard, that's, I think, exactly at the heart of this question is how do we move forward? I just said earlier, we can't be in lockdown for 18 months, but we can't let this virus go willy-nilly. And so what we have to craft is a response that says those who are lowest at risk for having severe illness, for having hospitalization, can we get them back into the workforce and into society in a quicker way, knowing that all the downsides of them not being in there, and let them choose. But I think your point about bubbling or protecting those people who are most likely to have severe illness, which is not going to be a perfect science. Some people very young will get the virus and die. Some people who will be older will get sick mildly and not suffer severe consequences. But in general, we know that age, we know that underlying comorbidities like heart disease, diabetes, hypertension, all are conditions that do predispose you, if you get infected, to having a much more severe outcome. So I think this is at the heart of what we're trying to promote right now for discussion. For some, it's a very hard discussion to have. It seems as if we're trying to put priority over some over others, or we may be putting some in harm's way. We're all going to be in harm's way until we get this virus eliminated as a human challenge by vaccine. And until then, we've got to find the creative ways to keep the world running and keep the virus at bay.
We'll keep the ethicists in business for the foreseeable future then. Dr. Olson, thank you so much for joining us here today. For all those tuned in today, please read everything he writes. Pick up his book, The Deadliest Enemy, A War Against Killer Germs. You won't be disappointed. Thank you very much. We greatly appreciate it. And I'll turn it back to our central authorities here. Thank you.
Thank you.